Hi, this is Barbara Wash with the Department of Medicaid Services. It is 10:59 and I'm still clearing the waiting room.
Hi, Barbara. Can you hear me?
Yes, I can.
Look at this new computer. I'm back in action.
That's wonderful.
We'll see how long it works before I break it.
All right, we're going to give it a few minutes because I'm still clearing the waiting room.
Thank you.
Mhm. So it's 11 a.m. and Lynn, and it's just you and Evan that are on at the moment. Should I still give it another minute or so?
Wait, have you heard from anybody, Evan?
Just from Marlene that she might not make it, and I think Teotis might have a conflict, so the only other person we'd be looking for is Susan, but I have not heard from her.
Oh,
Okay.
Susan's in the waiting room. She'll
Oh,
just be in a
perfect.
minute. Yes,
There we
yes.
go.
And that gives us the form, doesn't it? 3.
Yep.
Three.
Awesome.
Okay, Susan is on. There we go.
All righty. Are we ready to start?
Yes, we are.
All
There
right.
you go.
Good morning. We'll start with introductions. I'm Amlin Purden with Hazelwood Home Health.
Susan Stewart, Appalachian Regional Healthcare.
And I'm Evan Reinhardt with the Kentucky Home Care Association.
All right. We've already established the quorum. Do we have a motion to approve the previous minutes?
I'll make that motion. Susan Stewart.
I'll second it.
And I'll say aye since I'm the only other one. So that's pass. And Evan, if you want to do the old business, and I believe the new business is mine.
Yep. Really, we're just doing a touch base. I think there was supposed to be some discussion on the MCE side on the supplies limits conversation. So didn't know. I think Herb from one of the MCEs was going to take a look and kind of have a conversation at their next meeting. So just wanted to follow up on all of that, see how that went.
I'm Branch
Kelly?
Manager
Yeah.
in Physical Health. Um, the question about the supply quantity limits, is that for home health or for MSEA?
Home
It's
health.
yeah, it's for home health.
Home health.
Yep.
I don't see Herb on.
Herb's on.
Oh, he
there
is? Okay. I was running through all the people and I was like, I don't see him.
Did y'all have a question or just want to know there's somebody from Humana on here?
No, we were looking to follow up. I think Herb, you had said you were gonna, as the MCEs got together at one of their like Friday meetings, you were gonna have a chat about the supplies limits, and so just wanted to
Yes.
follow up on that.
Yes, we did. We did have a discussion with all the MCOs. None of them had an issue with it. But they did struggle with finding examples. I don't know
Okay.
if that was shared with the various MCOs, but um, all of them actually said that they were struggling to find examples where this was happening today. So they had asked that you all work with your contacts at the different MCOs to share those examples, and then if you do that, then I can pull it back into the group. In fact, after this call, I'll just send out an email to the rest of the MCOs saying that the home health TAC will have examples sent to the different MCOs as for us to then review and discuss in our next weekly meeting as an all MCO.
But I think that's not the answer to the question.
We said we were willing to do this, but the MCO saying they didn't have examples of where they were denying it for
Right.
all of it.
Correct. I understand that that's the answer, but that's not our ask. Our ask is, can we get a list of all the supply limits per item? That's our ask. So,
Hold on.
am I right, Evan?
No,
Yep.
no, that wasn't the ask. The ask was whether or not we were willing to pay up to the limit. Yeah.
So that's the kind of chicken or the egg, Herb, is, we need to know what the limit is to kind of figure out how not to get a denial.
Yeah, I remember that discussion. I remember them talking about how the vendor edits doing that was proprietary. And so that's when we said, well, somebody else said, well, why can't you just pay up to the limits? And then that's when I said, I'll take that back with the MCOs.
Well,
And I think that's our question is,
What is the limit?
well, it's not, I don't know that it is proprietary. Isn't that our question, Evan?
Yep.
We got an answer that it's not. Maybe for DME, but not home health.
I mean, I remember that call, and I remember the other MCOs on this call mentioning that the vendor edits doing this was proprietary. Who else do we have on this call from the other MCOs? I'm pretty sure that's what was communicated last time.
Okay, so what we need to get from the MCOs is what their limitations are for all of the home health supplies and provide that to the TAC. So when billing, they know what their limitation is. So all of the MCOs need to provide that data to the home health TAC.
Hey,
Whatever.
this is Erin with the department. Sorry, I'm a little late joining. Is Chelsea on with the MCO group? Because this was something she was working on. For a little background, this is something the TAC has been discussing for almost the entire time that I don't run anymore, had ran the TAC. So is someone from the MCO group on? Because they're supposed to be working on this.
I don't see Chelsea on here, Erin.
Okay. Okay. Barb, can you put that on the follow-up email for DMS, please, so that we can try to get this situated for the TAC, please?
Okay.
Sorry, I didn't mean to butt in, guys. I just had a little bit of background there, so.
Yeah, thanks, Aaron. I'm please understand. I'm not being difficult.
No,
yeah.
it's been a very lengthy ongoing discussion. So
Yeah,
we just want
I was trying to address something that was happening with the caveat of the other MCOs as well as Humana saying, these are vendors doing this and they're not sharing the logic necessary that's supporting their edits. And so I was like, well, what can we do to help you on in the interim, which was being able to pay up to whatever the limits are. And then that's what I was following back on.
Okay.
And that's why I was trying to be as open and visible as possible.
No, appreciate it. So again, sorry to butt in, guys.
Thank you.
no, thanks, Aaron.
And thanks, Herb. I wonder, like, when they're saying that they would pay up to the limits, or one examples where it wasn't paid up to the limits, are they talking about the published limits by Kentucky Medicaid? I mean, at least that would be an answer, that they're supposed to pay whatever Kentucky Medicaid would.
Yeah, so my gut feeling, I think I shared this last time, is that these are probably tied to NCCI edits. And I know we've talked about running around about whether or not they do or do not apply to home health. That's neither here nor there. But the thought was that when the vendor edits triggered, it says you build too many, that's fine, but don't deny the entire claim. Pay up to what is considered not too many, and then what's too many is what would then be denied. That was my takeaway from our last discussion that I brought back with the MCOs, that they said they were aligned with the possibility of doing that, but they just needed examples of where it was all of them were being denied, saying too many, so that they can go back and look at the logic with the vendor to see what can they do if they wanted to pay up to whatever that limit is.
And also the MCOs are required to pay the same as fee for service, they can do more, but they have to pay the same limitation amount, the same units. So a fee for service has a limitation of 5 units. The MCOs also have to meet that limitation.
And so are we saying that there's situations where we're not abiding by the published unit limitations from KDMS?
I can say, and if for me in the past, I know that's true. And I'm working with the biller this week because I have a relatively new one. My old biller was really good. She had played the whack-a-mole game and she knew what different ones would pay. And then she would go back and rebuild just for that amount. And probably tell you the truth, what's probably getting written off will amaze me when I sit down to work on it. But I'll actually look, since I'm working with her this week, and see if I can find some examples.
So I will say for Humana, and this is probably true for all the other MCOs, if there's actual published unit expectations from KDMS and the MCOs are not abiding by that, share those examples. If you've already shared those examples, maybe, and it was a few months ago, maybe it might behoove us to resend those to our reps. I will say for Humana, I'd definitely be interested in looking those examples to see why that would be happening. Because we would have an expectation of recovering at least the minimum of what KDMS would cover.
I'll work on some examples this week. I don't know if Susan has any.
Okay.
I'm gonna send an email out to the membership right now, to try to gather some up.
Perfect. Thank you. We want to be really good partners with you all. So it's, I get the frustration, and we'd be interested in looking at those examples.
Thank you.
Yeah, thank you. We'll get them to you as soon as we have them.
Yeah.
That all we had on that, Evan?
Yep, nothing else I can think of. So we're ready for our new business issue then.
So, Evan, I'm not sure who all you sent that question out to. I'm finding an issue. I know years ago, Medicaid published that if you're billing incontinence supplies, that you had to have certain codes, like being the top 3 codes for that patient to get those supplies paid, or get the supplies paid for that patient. So what I'm running into now is I have several patients that have both home health services and incontinence supplies. And in the past, we've always billed that together because we've put the supplies on the care plan instead of on a MAP 248 with different codes. And now I've got some denying, saying that their diagnosis doesn't support the incontinence supplies. So when I talked to the coders, because I'm not a coder at all, they said that, they had to code that for the services they were receiving. And the incontinence supply codes were on down. It might be number 10 on the codes. So I didn't know what the rule on that was exactly, because they have to code it per what the home health is. So should I be billing the supplies separate?
Actually, any of the incontinence diagnosis codes should be allowed on any number, step down number within the diagnosis listing, as long as it is a diagnosis of incontinence.
Okay.
It doesn't matter if it's the top 3 or if it's number 10. If the diagnosis just has to be on the claim.
Seriously, I think Aetna, they sent me when I asked them about how come they didn't pay it, and they said that they only had certain diagnosis codes and it had to be in the top. But anyway, I'll get with my Aetna rep to double check that.
I think you meant it had to be in the primary location, right? It's probably
right.
So like the primary reason for the treatment is incontinence, then you would have an incontinence supply. And I think that makes sense.
Yeah, but my problem is they're also getting home health services. So if we're seeing them for wound care, the coder said she has to code that claim or that care plan with the wound care first. So she always gets the incontinence diagnosis is on there, but it might be further down.
I see. Okay.
Yeah. So I don't know. And maybe once I get with Aetna, it might be that's what I need to do is just build the incontinence supplies separately. But in the past, I mean, I've been here 24 years and we've always built, if they were getting the services, we build it on the same claim.
So when you do that with your Aetna, maybe you want to share the two scenarios where, it is a standard home health and what if you were to change your primary to incontinence, what would happen? And then when it's the standard home health and you leave it with your standard home health diagnosis as a primary, but also have incontinence, then what would happen? Because
Yeah.
if you were to switch it, what you want to do is make sure it doesn't then start denying the other claims that you did not want to be denied.
Yeah. And even the primary, actually, I thought the primary diagnosis would cover it but the code list they sent had a generic code for that diagnosis, and we have a more specific code, but I'm like, it's all still the same thing. But anyway,
Yeah. Well, yeah, just make sure your primary obviously is not one of your secondaries, right? It can't be right. It has to be considered a primary diagnosis per the NCCI guidelines, right? And not a subsidiary of a primary diagnosis code.
oh yeah, you got too far into coding for me.
Oh, I'm sorry about that.
Yeah, you're like,
Because then you'll get
just
another
know that
edit.
it's number 1, 2, 3, 4, 5, 6.
Yeah, because you'll get another edit if you try to submit a secondary diagnosis as your primary, because it's something that's a subset of the primary. Right? So
Yeah.
complications of a flu, that's not your primary diagnosis, right? It's the flu.
Oh, yeah. But this one, and I never say the word right. It's cerebral palsy. I don't ever say that right, but they have the more generic code, and we have a very specific type. So I still thought it qualified, but they sent me a list that, starting in 2000 and something, you had to have a primary diagnosis of one of these to get it covered. And I thought, yeah.
I see.
Then when I talked to the coders, they were like, we're coding for the home health. and
I see.
and that's what it's supposed to be. So
Yeah. Okay.
all right. And then I just thought, well, maybe I do remember years ago that all came out that there had to be certain codes on the claim.
Yes.
And then I really didn't worry about it because I was like, they should be coded for that. And I've actually never had one deny for it until now. So, okay.
Yeah, I think CMS has gotten a lot more stringent on accurate billing guidelines, especially with the Affordable Care Act. So, it's progressively gotten more and more complex on the expectations for those billings. And one of them is tied to what's expected for a primary diagnosis code. And remember, everything we send to the state ends up going to CMS. So we're trying not to cause problems between the state and CMS either.
Okay. Thank you. I think that's all I had.
Okay, ready to go to our general discussion then? Any updates from the MCOs?
I guess Humana will continue and then I'll shut up because I've been talking a lot. No, I mean, I think from a home health, we've made lots of updates to try to fix stuff that we've had. I can honestly say I'm not aware of any ongoing or systemic issues tied to our home health. EVV has been going pretty well. I know we've seen some issues with providers tied to Therap, but outside of that, and one other thing, I'm not sure if that's part of this TAC, is hospice. Is hospice part of this group? Okay, well then we're good. Then yeah, nothing else for Humana.
Thank you.
Thanks, Herb.
Hi, this is Anna Page with Passport, and I do not have any updates unless you have any questions.
Thanks, Anna.
You're welcome.
This is Aaron Allen with WellCare. We don't have any updates.
Hi there. This is Ashley from Aetna Better Health. Just to, I guess, respond back on those specific diagnosis codes real quick for incontinence supplies. I do have that list if you do need it again, and I'm reading it now, it does say it needs to be listed in the primary position. So that was, I think, an update from 2023. So there hasn't been any new changes. So it might have just been the diagnosis on your most recent ones was not one that's on this list.
Yeah.
But if you do need that again, I can get that over to you.
Yeah, they sent it and I thought it was like
Okay.
I thought it covered it, and then Medicaid just said that, or somebody said that it just had to be a diagnosis. It didn't have to be a primary. So
Oh, I gotcha.
yeah,
I can
and I
follow up with our team on that. I know the network notice that went out, it does say primary position. But we can always
yeah.
get
So it's
clarification.
really in conflict because the coder said that they can't code it just for the incontinence supplies, which I
Mhm.
understand they've got to code it for the services we're providing also. So I don't know. The answer might be is I just need to bill it on a separate
On a separate one,
plane. Yeah.
right?
But I'll get with my rep.
Okay. Otherwise, I am not aware of any recent PA issues or billing. Things seem to be okay for Aetna. Thank you.
Thank you.
Mhm.
I think we just have United. Anybody from United?
Yes. Hi, it's Suzanne. I was kind of waiting for everybody. Hello, everybody. I don't have any updates. I am curious about any examples you guys can give us, though, of the home health limits issues. If there's anything that you can give us to go back and research, that would be really helpful. But I'm not aware of any issues at this time. So really no updates other than that.
Thank you.
All right, down to updates from DMS and Commissioner Lee.
Evan, I've got a question. I don't know if it's appropriate here or not, but on our next agenda, can we have something from DMS related to EVV? You know, what they're seeing as far as denials, or, you know, I'm not ready to present anything yet. Just curious how it's going, what they're seeing across the states from a denial standpoint.
Did you say EVV or EED?
EVV, electronic visit verification.
Okay. Okay.
Actually, Susan, are you swimming in denials? I feel like I am. That's why one of the reasons I'm going to sit with the biller this week.
I don't know if I am or not. I probably need to follow up, but I would be interested to see what the DMS side sees from a EVV, a year's worth of data almost now. You know, is it working? Is it not working? I mean, we still get a lot of no service stuff, and it's labor intensive to try to get everything in place to get paid. So I'm just curious what the stance of DMS is.
Are you talking about like in EVV when they log in, the GPS doesn't pick up the little pointers, they're in the exact right place, but it'll say it can't tell where they're at. Yeah, I get a ton of that.
Susan, this is Erin. We can make sure. I don't think April Lowry was able to be with us today because of a conflict, and she oversees that. But if the TAC would like in the December meeting under new business, you could always ask for like a data report to be presented. You guys typically meet what, February, even months. So that could be something that you could make the request in December to be presented at the next year's meeting, if you'd
Okay.
like.
Thank you, Evan. Help me remember.
Yeah,
Barb, can
we'll do.
you add that just as a reminder on the DMS follow-up for me, please?
Yes, I will.
Thank you so much.
Mhm.
All right. Any other updates from DMS or Commissioner Lee? So we'll add the EVV information on denials and other issues as a follow-up. And then I think we're down to recommendations, which none for today, but maybe some next time around. And Susan will be our MAC rep. So next meeting coming up December 9th. Unless anybody has anything else for the good of the order, I'll turn it back over to Anlin for adjournment.
All right, don't guess there's anything else. I'll make a motion to adjourn.
I'll second.
You agree, Evan?
Aye, yes.
We are all in agreement.
Thank
Thanks, everyone.
Thanks, everybody. Appreciate it.
Have a
Thank
good
you.
one.
Have
Thank
a good
you.
day.
Have a great day.